major challenge that was posed by Dr. Ramos is that when you actually look at the list of interventions that were shown earlier, there was actually nothing new there. One of the first things that we did when we looked at how to possibly plug this is to actually estimate how much money do we actually need to possibly deliver the services. And given the magnitude of the problem, we made our estimates and came up with a figure of a shortfall of about 6 billion pesos just to fully take care of the needs of the poor, accounting for roughly what we estimate as already existing within the system, coming from PhilHealth payments, DOH budgets, as well as what we estimate to be LGU spending for family planning and maternal care. But actually, even if we don't have the 6 billion at present, we actually also looked at experiences across the country on how local health systems strive to manage and cope with the situation. And the example that will follow is an illustration from one province on how the gaps can possibly be plugged. So let me walk you through the example of what happened in Davao del Sur when the Department of Health, together with the provincial government and its partners, came together to try to address the very specific problem of preventing maternal deaths in a given province. Davao del Sur has around 20,000 women with unmet need for family planning among the poor alone. And among the poor as well, we know that there were about 6,000 women who delivered at home in their previous pregnancies, and therefore we count them as unmet need for facility-based deliveries. When you look at the map, you will actually see that there are different shades of gray that divide the municipalities across the province. The intensity of the color actually denotes the concentration of CCP households in specific municipalities. You will note that, in particular towards the southern part of the province, this is the capital city of Digos. In the southern part of the province, there is a high concentration of poor families, and the areas with crisscross shading actually denote that this is more than 2 hours away from the nearest facility that can do cesarean sections. If you meet an obstetric emergency in this area, the woman would likely die. And the facilities and providers in the area, as expected, would be clumped together in the cities of Davao and Digos. The first thing that was done in the area of Davao del Sur was to start off with a list of households from the CCT program of DSWD. And this is one example of Dr. Garin's admonition or call for a full government approach in dealing with health problems. This is not a DOH problem alone, and the solutions are not totally within the control of the department. So we got the CCT list. We started off by making use of the existing platform for conditional cash transfers because number one, there is a list of people with names and addresses. And second is, families are required to attend monthly family development sessions, in effect giving us an opportunity to talk to a captive audience. And given that we don't have enough barangay health workers and other community health workers to deal with these families, which we consider to be outside of the system prior to the launch of the CCP and NHTS programs, we engaged the municipal links and the parent leaders, and also in effect, ask them to take on some community health worker functions of informing families. Using the family development sessions, we were able to identify women with unmet need for FP and those that were pregnant, and they were assisted in developing health use plans, meaning they were walked through a series of procedures for them to be able to reach a facility when the time comes. And this was also the venue wherein PhilHealth stepped in and provided information on the status of their membership and their entitlements. In parallel to that, an effort was also done to locate and assess the capability of facilities in terms of what services that can be offered and the load at which that they can carry, particularly if they can still carry additional load. As mentioned earlier, Even if government facilities are accessible, sometimes the beds are full and patients are turned away. And we also looked at their PhilHealth accreditation and participation status in terms of delivering benefit packages, because we can only negotiate for no balance billing among facilities that have accreditation and are eligible to receive reimbursements. Next came the matching of the beneficiaries with the providers, and this essentially required 3 steps. Number one, on the side of clients, we needed to inform them that they're entitled to these services and that they can seek care from these providers. Providers were also informed and were advised to expect specific families to show up at their doors, that they will seek care, and they were given names in advance, that these are the expected names of pregnant women who will knock on your doors on specific periods. And again, the parent leaders of the CCT program, as well as the BHWs in the area, were oriented to help families navigate the health system, as what was mentioned by Secretary David earlier. Who would help our families navigate the health system? It took a former Secretary of Health to help that housemaid to actually seek care properly. In these areas of Davao del Sur, we relied on our parent leaders and our BHWs to actually navigate for the family. But that would not be enough, and we know that there are deficiencies in our system that could not be plugged immediately. And one particular example is that I mentioned to you that the southern part of Davao del Sur had a high concentration of poor families, are more than 2 hours away. And if you notice, the road network only ends at this part. There are no roads down here that you can talk of except for probably logging roads and trails. Traditionally, families take a boat and travel all the way from this part going to the capital of Digos, and during the season of Habagat, where the waves are big, that access is essentially closed. And so, in the existing road network, families were assisted to connect to these road networks by having emergency transport and communication networks set up. And this is not your ambulance, this is your tricycle, your habal-habal, skylab, etc., whatever exists in that particular area. Halfway homes were also established. We did set it up. We rented facilities, meaning the provincial government of Davao del Sur rented facilities in Digos for families or mothers that come from far-flung areas where they could stay and wait for their delivery. There were also times when we assessed Davao del Sur Provincial Hospital and found that it was operating at full capacity, so it could not take on additional cases of normal deliveries and cesarean sections. We were able to convince 2 private facilities, one level 2 facility, Medical Center of Digos that can do cesarean sections, and Barony Hospital in a municipality just outside of Digos that can do normal deliveries. The municipality of Sarangani, unfortunately, is totally cut off from the whole province. And instead of bringing the clients all the way to Digos where care is available, the province talked to the city of General Santos for joint use of their city hospital. And lastly, while this is not an example for Davao del Sur, but it's actually an example that's also commonly now found in many provinces, the access to specialist services can be also achieved by coming up with novel PhilHealth revenue retention arrangements. Dr. Marie will be particularly pleased with this because she comes from this area. This graph, it actually comes from the Leyte Provincial Hospital, illustrating how the hospital was able to raise PhilHealth shares, PF shares of physicians from PhilHealth from 3,000 in 2005 to as high as around 180,000 in 2011. This is actually 180,000 as well. That's a typo error there. What I understand from Leyte Provincial Hospital now is there's a long line of residents lining up at their doorsteps applying for positions in that hospital. And then lastly, there was extensive monitoring done using health use plans, as well as direct feedback during family development sessions, asking families how happy they were and what problems they encountered in using services. In a period of 5 months, the combination of these interventions were actually able to raise use of family planning services and facility-based deliveries. And if you notice, Davao del Sur actually posted the more modest gains. We actually had much more success in other provinces in the area. The message for this slide is that even under our current dispensation and our current operating environment, the Department of Health and local governments in the country, particularly 5 provinces doing this demonstration study, can actually say that this can be done. So we will end our presentation there, and we look forward to actually giving more presentations on other areas. Our presentation is actually just the maternal and neonatal mortality chapter, and this is the overall vision of the health sector review document that the project is planning to produce. Thank you very much.